Welcome to the Brain Matters webinar. I'm Dick Moberg, your host for today's presentation. Our featured panelist is Dr. Brian Appavu, and our featured industry partner is Persist Development. We'll first review a few upcoming meetings and then get right into a recorded presentation from Dr. Appavu, followed by a short presentation by Persist. At the end, we'll have a live question and answer session with Dr. Appavu. So please type in your questions using the Q&A tab on your screen anytime during the presentation. Now let's look at some upcoming meetings. All of these meetings are listed in the events section on our website, www.moberg.com. In August, we have Neurotrauma in Toronto, then the Asset Meeting for EEG Technologists in New Orleans. There's an ENLS course put on by UC Davis at the end of August. And of course, in September, we have the ICSD Spreading Depolarization meeting, which will be a satellite meeting just prior to the Neurocritical Care Society meeting. Both of these are in Boca Raton, Florida. Later in October is the Newborn Brain Symposium at Brigham and Women's. This is a good time to remind you about our newsletter, the Neuroscience Monitor, which will keep you up to date in neuromonitoring. Your colleagues can sign up anytime on our website. If you have an event or news item related to neuromonitoring and neurocritical care, please send it to us. By this time, I hope everyone has figured out how to get onto the webinar, so let's move on to our featured panelist. Today's panelist is Dr. Brian Appavu at Phoenix Children's Hospital. We caught up with Dr. Appavu in Phoenix earlier this month to film the webinar. As most of you know, it's generally over 100 degrees every day in Phoenix this time of year, but it's a dry heat and not really that bad. But they have some excellent cold beer, and Brian showed us some of the best Mexican food in town, which took the focus off of the heat. So at this time, let's get right into the webinar.
Hi, I'm Dr. Brian Appavu here at Phoenix Children's Hospital. I am a clinical neurophysiologist and ICU neurologist at the Barrow Neurological Institute at Phoenix Children's Hospital. Phoenix Children's Hospital has a 48-bed pediatric intensive care unit and is Arizona's only level 1 pediatric trauma center. Here we take care of a large volume of severe traumatic brain injury in children, as well as other conditions such as cardiac arrest, patients with ECMO requiring advanced neurological monitoring, and patients who have AVM ruptures. Here, I serve as one of the ICU neurologists providing consultations in the intensive care unit, and I use advanced multimodal monitoring techniques to be able to better evaluate the brain and be able to provide the best care for our children and their families. I'm looking really forward to showing you some great data on this webinar. So we're going to talk about electroencephalographic patterns in neurocritical care as they represent either epiphenomena or direct contributors of brain injury. So my objectives are, I want to provide you with a brief overview of the nature of electroencephalography. I want to discuss the relationships of seizures, Ictal-Interictal Continuum patterns, and other changes in EEG background as they relate to cerebral pathology, blood flow, and metabolism. And I also want to provide you with an overview of multimodality monitoring cases that demonstrate the utility of EEG in understanding real-time cerebral physiology. So in the intensive care unit, we are involved with complex data from multi-neuromonitoring tools. This can include intracranial pressure monitoring, transcranial Doppler ultrasound, brain tissue oxygenation, near-infrared spectroscopy, as well as measurements of the peripheral body with blood pressure, heart rate, body temperature, and CO2. But today I'm going to really focus on EEG because that's a tool with a lot of character to it, a lot of high-resolution information that often goes unrecognized in terms of its relationship to cerebral pathology in real time. So this is what EEG looks like. This is sort of the EEG of a normal patient. It this is a patient that's not seizing. Now, usually in the intensive care unit, when a patient's hooked up to an EEG, most of the time the data that people are looking for historically is to whether they're seizing or not. But as you can tell on this, even without knowing anything about brain waves and electroencephalography, is that there's a lot of high-resolution information within it. There is a lot of character to it. There's a lot of pieces to it that one can try to decipher to better understand what is the nature of the brain at this given time. And so as someone with a little bit of a musical background, I find EEG to be very similar to looking at an orchestra. So in the EEG, you should have symmetry between both sides. Here, the blue the blue area represents the left hemisphere. The right colors look like the right hemisphere, and the green represents sort of the midline parasagittal electrodes. And there is a level of symmetry that you see between both sides and a level of synchrony. And if you think of a orchestra, as you can see in this figure down on the lower right, an orchestra has its own degree of synchrony to it, or symmetry to it. And the music that is produced has its own synchrony that you can hear. In addition, if you think about an orchestra, you think about the back of it, you have a rhythm coming from the percussion section. Just above that, you have high volume, low frequency instruments like trombones and trumpets and tubas. And as you come anteriorly or towards the front of the orchestra, you have higher frequency, lower volume instruments such as piccolos or flutes or violins and whatnot, and cellos. And then in a similar way, an EEG has its own anterior to posterior gradient. In the back, where these sort of occipital O1, P3, T5, O2, T6 electrodes are, you can see that there is a posterior dominant rhythm. It has its own rhythm. That rhythm sort of sustains as a higher amplitude, relatively low frequency type of waveform. And as you move closer to the front of the brain, you start to have higher frequency, lower amplitude activities. So just like an orchestra, it has its own anterior to posterior gradient, it has its own symmetry, and essentially it has its own sense of organization. And as such, when we think about music and music coming from an orchestra, any particular piece of music has its own character and its own individuality. Each song has its own tempo, its own harmony, its own melody. And for any given EEG, for any given patient, it has its own individual characteristics. Each patient may have its own amplitude, its own arousal patterns, its own variants that distinguish it within as its own. But what we find is that when we look at the similarities between music and EEG, it's just there are similarities, like a musical score that resonates and really compels us. An EEG background has its own sort of organization and functionality to it, and the degree of organization, structure, and the degree of sustained rhythms that we see on an EEG can be indicative of functionality. And this is something that we can follow to better understand what's going on with the patient. Furthermore, I want to sort of highlight, the challenges we have with pediatric EEG and the features and commonalities that we see. So as the child develops, and from the neonatal period up until the teenage years, there are changes in continuity, in amplitude, in organization, and in rhythmicity that we can see as that patient grows up. And knowing how that changes, especially in a child with traumatic brain injury or any sort of acute brain injury, helps us better understand as to whether pathology at a given developmental stage is significant or not. And so when we think of EEG and acute brain injury, sometimes we lose some of the patterns of this organization. And there are features that we look for to better understand what is actually going on at that period of time, and how these patterns of this change in organization, rhythmicity, or structurality really change, and what they mean in terms of cerebral physiology. So as I mentioned before, we have historical use of EEGs. So why have we monitored EEGs in acute brain injury? Historically, it's really been for the detection of seizures and status epilepticus. So we define status epilepticus as a condition resulting from either the failure of mechanisms responsible for seizure termination or the initiation of mechanisms which lead to abnormally prolonged seizures. And we know that status epilepticus can have long-term consequences, including neuronal death, neural injury, alteration of neural networks, and they just really depend on the duration of the seizures and the type of status epilepticus that occurs. We know, based on medical literature done over decades, that status epilepticus is associated with excitotoxic injury, and there can be a hierarchy of selective hippocampal neuronal damage that occurs over a period of time. Status epilepticus is associated with energy failure at a cellular level, and this ultimately leads to necrosis. There can be a recovery phase after status epilepticus in which we have recovery of that swelling, but at a cellular level there can be subsequent apoptosis and delayed neurological injury that can happen as a result of that and be a result of the burden of status epilepticus. Now I wanted to go from status epilepticus to sort of discrete seizures. We know that there's a physiologic impact of seizures in non-critically ill patients. And we know this because we use that physiology to better understand epileptogenic zones in epilepsy patients. We know that with seizures, there's a transient increase in regional cerebral metabolic demand, and there's subsequent compensated increase in regional cerebral blood flow. And in these situations, supply equals demand, so any individual seizure in a non-critically ill patient typically does not cause brain injury if it's of a short duration. A perfect example of the utility in this is the utilization of SPECT scan in epilepsy surgery evaluations. And when you perform a SPECT scan, you wait for a patient to have a seizure, you inject dye immediately when the patient has a seizure, and then you send them for a scan, and you look for the area that has the most blood flow, and that is supposed to represent the area of the epileptogenic zone. In those patients who are critically ill, however, we know that there is impaired autoregulation. We know that compensatory mechanisms against neurology injury are compromised, and we know that supply does not equal demand. So in these situations, seizures may not have that sort of energy match to be able to keep brain injury from happening. And therefore, it's important for us, given that, to be able to treat seizures in the setting. We do know, based on epidemiological studies, that seizure burden, particularly in children, is independently associated with short-term outcome, and that the maximum hourly seizure burden is associated with odds of neurological decline. So I want to go back to sort of a fundamental question that might sound crazy to ask, but it's certainly important, and I sort of highlight on it. Why do we treat and monitor for seizures? Fundamentally, we have to break this all back down. It's about preventing secondary neuronal injury. We know that there's death by homicide with the energy mismatch, and we know that there's death by suicide, as I mentioned later, where you talk about that programmed cell death that happens after the acute insult. And so it becomes important to us to really take that step back and think about what do we know about seizures and other patterns we can see on EEG as they relate to cerebral bioenergetics and cerebral blood flow. So we have some literature that has looked at time-synchronized physiologic data in relation to seizures and of themselves and critically ill. This was a study from Paul Vespa at UCLA looking at the usage of cerebral microdialysis during severe traumatic brain injury, finding that patients with non-convulsive seizures demonstrated elevated lactate to pyruvate ratios beyond post-injury hour 100, suggestive of a metabolic crisis, and that those same patients demonstrated a higher intracranial pressure profile beyond post-injury hour 100. When we look at time-synchronized physiologic data in non-convulsive seizures after aneurysmal subarachnoid hemorrhage, we found unique physiologic changes as well. This was a study from Dr. Jan Clausen at Columbia University, where they showed that in the time after a seizure onset, immediately, actually before obvious electrographic onset, we see a trend in rise in heart rate, blood pressure, respiratory rate, cerebral perfusion pressure, and intracranial pressure. In the 0 to 5 minutes after that, we see a transient increase in cerebral metabolism and an increase in intracranial pressure. 5 to 15 minutes after that point, we have evidence of brain tissue hypoxia. And then in the 15 to 30 minutes after seizure onset, regional cerebral blood flow appears to increase. So what about brain physiology, the physiologic impact in pediatric brain injury? Well, there's limited data on this, but I think that's going to be changing in the next few years. And I want to give you an example of some patients we've had here and what we've sort of observed at Phoenix Children's Hospital. So this is an example of a 7-month-old girl who experienced superrefractory status epilepticus. At one point in her course, she had discrete seizures on EEG, which you can see right here on the top right raw EEG pattern. And so what I've done here is I have a trend of multimodal monitoring physiologic parameters over a time window of 4 hours. Looking at the bottom, you see the dense spectral array, and that you can tell on there when discrete seizures were occurring. And you can see that between 3 p.m. to about 7 p.m., 1500 to 8 for 1900, those seizures really started to pick up. You could see that seizure on total power, spectral edge frequency, median power frequency. You could see it as a reduction in interburst interval and as an elevation in amplitude integrated EEG and an increase in the suppression percent. Actually, sorry, a decrease in the suppression percentage. And what's interesting about this is you look at the physiology when this happens. For each of these elevations, you do see a transient increase in mean arterial blood pressure. You see a rise in respiratory rate. And more interestingly, you see a decrease in cerebral arterial oxygen saturation as measured by the NIRS, here with measured as RSO2. You see with each of those seizures, you have a relative reduction in brain oxygen saturation. Also, you can even see for this patient, a 7-month-old, that these seizures also seem to have an effect on peripheral oxygen saturation as measured by the SpO2 percentage. Here is with the same patient. This is an example of the patient having a discrete prolonged seizure over several hours from about 00:30 to 2:30. And you can see here during that entire seizure, brain oxygenation decreased with the NIRS. What's interesting about this particular pattern is if you look really closely at that spectral edge frequency, that total power, and the dense spectral array, there are intermittent periods of time during this prolonged seizure where the frequency and amplitude of the seizure in and of itself increased. And when you see that happened, you can see that there are relative reductions in brain oxygenation that proceed those higher frequency activity. And so what this tells us here is even within a seizure, how rhythmic or how fast that activity for this given patient is really has a relationship with how degree to what degree brain hypoxia is really occurring. So the recognition of status epilepticus and repetitive seizures being contributive to neuronal injury has led to an increased utilization of continuous EEG monitoring. And over the last several decades, we have identified other unique EEG patterns of unclear significance. And many of these are what we refer to as the Ictal-Interictal Continuum. The Ictal-Interictal Injury Continuum was first sort of described in 2005 by Dr. Derek Chung and Dr. Larry Hirsch at Columbia University at the time, and they sort of produced this very nice diagram in the Journal of Clinical Neurophysiology at that time, which describes some of these patterns and what their putative relationship was to both neuronal injury and towards a risk of seizures. And sort of, while these patterns have been described, they never were really summarized, to the best of my knowledge, in a very specific definition. And so in my review paper in Neurocritical Care last year, Dr. Jim Riviello and I sort of described it this way: a dynamic pathophysiologic state of unstable neurological processes that, while not always ictal, suggests an increased risk to evolution to the ictal state. So how do we characterize each of these patterns? Where the American Clinical Neurophysiology Society has come up with some nomenclature in 2012 that you can find online, and they have a nice PowerPoint online that you can look at to better understand these patterns. I'll show you a few examples of what comes from their website. And so they've sort of broken this down into a couple different terms. So there's main term 1, which sort of describes the location of these patterns, whether they're generalized, lateralized, or multifocal. Main term 2 to describe what sort of pattern it is, whether it's periodic discharges, bilateral independent, rhythmic delta activity, or spike and sharp wave activity. And there are modifiers to it that really describe sort of characteristic of what these patterns have. So I'll go through a few of these. There's rhythmic delta activity that manifests as delta activity with relative uniform morphology that's monomorphic and a duration of 4 Hz or less without intervals between them. These can be frontally predominant, occipitally predominant, or midline predominant, and they can have, or they can be lateralized, and they can have modifying features. So this is an example of generalized rhythmic delta activity that's frontally predominant. You can see in the frontal lead, you see this monomorphic 2 to 3 Hz, actually more so 2 Hz activity over those regions. And here's an example of lateralized rhythmic delta activity here over the left temporal region. And this activity actually, if you look at that T3, T5 area, you see that it's pretty sharply contoured. And because of that, you add a modifier to it, the plus S modifier, to better characterize what this pattern is. Again, these are all slides. These figures are directly taken from the ACNS PowerPoint that you can view online. So when we look at lateralized rhythmic delta activity, we find that it actually has an association with several acquired neurological injuries, such as intracranial hemorrhages and subarachnoid hemorrhages, and they actually are a pretty substantial independent predictor of seizures in and of themselves. I want to go into periodic discharges. These are stereotype repetitive discharges that occur at regular intervals. In the 2012 criteria, these used to be called PEDs, or periodic epileptiform discharges, and that in 2012, that's the epileptiform classification sort of went away, given a lack of consensus as to whether these always confer a propensity towards seizures or not. So now we call these PDs, or periodic discharges. Here's one example of generalized periodic discharges for GPDs. These are generally synchronous with amplitudes relatively equal across homologous regions. And these can be seen in a diverse setting, such as hypoxic ischemic encephalopathy, as well as metabolic encephalopathy, such as hepatic encephalopathy or toxic metabolic encephalopathies. These have been associated with seizures to a strong degree, and they do carry a high association with mortality. I will mention, and sort of go back to it, that we do often see generalized periodic discharges as sort of a pattern seen after we come off of certain types of strong anesthetic medications, such as pentobarbital. This is an example of lateralized periodic discharges. Unlike generalized periodic discharges, these are maximally involved over one particular hemisphere. As you can see here, these represent spikes and sharp waves that have a relatively periodic pattern over the right temporal area. And sometimes we see these patterns with superimposed fast activity or polyspikes within it. And in such cases, we give them a modifier, so we would call this LPDs plus. And here you have superimposed faster activity, so this would be LPDs plus F to represent that fast activity. It's been looked at in terms of what is the association of these Ictal-Interictal Continuum patterns with a risk towards seizures. And we found some unique frequency-dependent features. What was observed in this study by Dr. Andres Rodriguez using EEG activity from the Critical Care EEG Monitoring Research Consortium is that lateralized periodic discharges appear to be associated with seizures at all frequencies with and without a plus modifier, and that lateralized rhythmic delta activity as well as generalized periodic discharges appear to be associated with seizures in a frequency-dependent manner, those that were 1.5 Hz or faster. And what was noticed here also was that generalized rhythmic delta activity was not associated with seizures. And so this study sort of gave us a unique perspective into the fact that some of these patterns have a frequency-dependent propensity towards their association to actual seizures. So there are challenges within the Ictal-Interictal Continuum. There is no clinical gold standard that exists for qualifying an ictal pattern. Most studies of the Ictal-Interictal Continuum focus on etiology, prognosis, and association with seizures. And so how do we qualify patterns of the Ictal-Interictal Continuum as either epiphenomena of neural injury or direct propagators of it? So to answer that, we really have to look at what is this association with cerebral blood flow and metabolism. And we've traditionally had two ways of doing that. One was functional neuroimaging, and the other with multimodality monitoring. So we have some case series using functional neuroimaging techniques that are quite unique and quite insightful. This was a case series of 18 patients with lateralized periodic discharges, where they found that using SPECT scan during this Ictal-Interictal Continuum pattern, they were able to see that there was an increase in regional cerebral blood flow in the particular areas where those periodic discharges were occurring. And in 3 of those patients who had lateralized periodic discharges go away or resolve, there was a resolution of that increase in cerebral blood flow. We have a nice case report here of using MR perfusion to make a treatment decision on 2 patients within the Ictal-Interictal Continuum. Each of these patients had lateralized periodic discharges. One had hyperperfusion seen and was given during that pattern, had aggressive AED treatment for it and had clinical improvement. They described also another patient with no perfusion asymmetry during those lateralized periodic discharges. They didn't do any escalation of anti-epileptic therapy for that patient, and then lateralized periodic discharges spontaneously improved. Dr. Eric Rosenthal at Massachusetts General Hospital published this study showing the correlation of PET scan and metabolism during such patterns. And so this was a study looking at 18 patients with structural lesions or inflammatory lesions or actual epilepsy. And they found that during these patterns that hypermetabolism was very common and actually predicted status epilepticus. And sort of on the basis of this, he and his group published this paper and have a nice figure that sort of updates that Ictal-Interictal Continuum figure, which I described earlier, which really shows that that some of these patterns may have an association with increased metabolism. I want to move forward to talking about some of the studies that have recently come out, really showing multimodality monitoring and its relationship to the Ictal-Interictal Continuum. So in 2016, Dr. Jan Claassen and Paul Vespa over at both Columbia University and UCLA put together a 2-center cohort of patients with adult traumatic brain injury who underwent cerebral microdialysis and correlated it, those results with Ictal-Interictal Continuum patterns as well as seizures. And what they found was that in this cohort of 34 subjects, metabolic crisis was observed during both seizures and periodic discharges, including those periodic discharges that were not associated with seizures. And metabolic crisis here was measured by elevated lactate to pyruvate ratios. In January 2017, Dr. Jan Claassen and his group at Columbia University published this study in JAMA Neurology looking at periodic discharges and their frequency and finding a frequency-dependent relationship with brain tissue hypoxia. And so this was a cohort of 90 patients at their unit with aneurysmal subarachnoid hemorrhage. And what they found was that there was a change point analysis confirmed a temporal association of periodic discharge onset at a frequency greater than 2 Hz and brain tissue oxygenation reductions. They found increases in regional cerebral blood flow and global cerebral perfusion pressure for all higher frequencies, and they concluded that the physiologic signature of high-frequency periodic discharges resembled that of seizures. That if you had those discharges at 2 Hz or greater, that even if they didn't have ictal evolution to them, they were associated with brain tissue hypoxia. So another pattern that I want to talk about, and I have a little bit of work on, is stimulus-induced rhythmic periodic or ictal-appearing discharges. These are a Ictal-Interictal Continuum pattern that seems to be consistently induced by alerting stimuli such as auditory stimuli, sternal lobe examination, suctioning, or turning. So these were initially described at Columbia back in 2004, and they were subcategorized as those which had periodic discharges, those that had an ictal evolution, and those that were associated with sort of this frontal or generalized rhythmic delta activity. And there have been studies that have looked at their associated factors and prognostic implication, and most of the studies that have been come out really have not shown that they are independently associated with in-hospital mortality. During my fellowship time at Columbia University, I was involved in studying the association of SERPID duration with brain tissue hypoxia. So we looked at adult patients at Columbia University Medical Center with high-grade aneurysmal subarachnoid hemorrhage who underwent continuous EEG and multimodality monitoring. And we looked at, as a primary outcome measure, brain tissue oxygenation as it related to SERPID duration. What we found is in our cohort is that SERPIDs that were lasted greater than 5 minutes or longer were associated with reductions in brain tissue hypoxia at a statistically significant magnitude, and that events lasting at least 10 minutes or longer were associated with brain perfusion increases. And it was these results, which we discussed at the recent Neurocritical Care Society meeting, that suggested that SERPIDs may act like seizures in status epilepticus in terms of the duration of them may have a relationship to its impact on cerebral physiology. I want to talk about EEG and how it relates to cerebral ischemia. We do have some data that shows us that EEG activity does relate to cerebral blood flow. This figure was taken out of a very nice review paper done by Dr. Brandon Foreman and Dr. Jan Klaassen back in 2004. We know that as cerebral blood flow decreases within the brain, that there's a relative loss of faster frequencies. And if we really lose blood flow and get below 10 to 12 milliliters 100 grams a minute, the EEG can be suppressed. And so it's this feature of EEG that really allows us to understand cerebral blood flow with high temporal resolution. So this work has led to this sort of principle has led to a lot of unique work in terms of looking at delayed cerebral ischemia in aneurysmal poor grade subarachnoid hemorrhage. This was a study produced in 2004 at Columbia University where they looked at those patients who had Hunt-Hess grade 4 or 5 aneurysmal subarachnoid hemorrhage, and relative reductions in the alpha-delta ratio seem to have a strong relationship with the development of delayed cerebral ischemia from cerebrovascular vasospasms. I want to touch on cortical spreading depolarizations. This was a topic that has been discussed by Dr. Foreman and Dr. Hardings in the past, but I want to touch on it. Cortical spreading depolarizations represent a transient and terminal depolarization of human cortex that correspond with the depression of spontaneous electrical activity, otherwise termed cortical spreading depolarizations. Oftentimes, these are associated with an early hyperemic response followed by prolonged oligemia after neural depolarization. However, at times we can see that this can, in a critically ill brain, that this can be associated with an inverse hemodynamic response and spreading ischemia. Cortical spreading depolarizations have been associated with delayed cerebral ischemia in aneurysmal subarachnoid hemorrhage, and they have been associated with patients with poor outcome in patients with traumatic brain injury. At this point, I want to discuss a couple case examples we've had here at Phoenix Children's Hospital where we've really used some of the principles that I've discussed thus far in guiding clinical management for some of our patients. So this was a patient I took care of not too long ago. It was a 6-year-old girl in our cardiac intensive care unit who woke up with difficulty talking and some right facial droop. We actually brought her down for a scan and relatively urgently, and we found that she had a total occlusion of her left M1 cerebral blood, her left M1 middle cerebral artery. And we found that there was diffusion restriction that correlated to this, but that there was not an extensive infarct. So on the basis of this, we talked with our neurointerventional team, and we were able to successfully perform a mechanical thrombectomy to remove the clot out of her brain. After this was done, we brought her back to the CVICU, the cardiovascular intensive care unit, and we placed her on continuous EEG monitoring. And what we did is that we were able to trend the alpha-delta ratio to be able to understand how well our patient was perfusing, and also look for the risk, her new onset risk after a thrombectomy. You really worry about hemorrhagic transformation. And so what we did is we sort of hooked up the EEG, we did trending of the alpha-delta ratio at the bedside, and I sort of created this the diagram you see on the left. I sort of made this available to our nursing staff. So immediately after we hooked her up, there is a difference in the alpha-delta ratio between the right and left side. The right is red, the left is blue. Left represents as you can see here, the left hemisphere alpha-delta ratio is lower than the right. And the real reason for that at this point, which you see on the arrow, is that there's a lot of slowing high-amplitude delta activity immediately after this thrombectomy on the left hemisphere. So what I asked our nurse to do is sort of keep an eye on that trend and let me know, give me a call if there is a change in that alpha-delta ratio where that left side, that lower left trend starts to diverge away from the red line, the right hemisphere. And what we saw over time, and I'll go to a few hours later, is that alpha-delta ratio sort of normalized between both hemispheres. And what we see at a later time point here is that the two hemispheres normalize, and we see a greater degree of faster activity over that posterior left temporal region that was either mostly monomorphic delta activity, as you saw in the prior EEG. And what this allowed us to do is really understand that there was a greater degree of perfusion that happened over time after this mechanical thrombectomy and led to increased faster activity on our EEG. And so how could this have guided clinical management? Thankfully, this patient really did well. But should this patient have had reocclusion, a hemorrhagic transformation, or something worsen, we could follow and trend that alpha-delta ratio to really understand how things are changing in real time. I have another example here. This is a 9-year-old girl with 3 days of fever and upper respiratory infection symptoms who presented after she stopped talking. We hooked her up to EEG and we found that she had periodic discharges. And if you really look at them on here, you can see that they have they're maximal over the left hemisphere. So how can we determine whether this pattern is ictal or interictal? Well, what we did is we hooked her up to transcranial Doppler ultrasound. I actually performed a bedside TCD at the time of this EEG. And when we looked at her left middle cerebral artery, we saw that her mean flow velocities were greater than 100. Here you have a mean flow velocity of about 109, which is elevated and may represent hyperemia. And so on the basis of this, we sort of made a treatment decision to treat her within the Ictal-Interictal Continuum, as though this is more correlative of seizure activity or active pathology. So we treated this patient aggressively, and she improved. Her EEG started to normalize over a couple of days, and she started talking again. This is an example of, right here, you have on the bottom right of her diffusion restriction abnormality within that left temporal lobe. Here's another case. This is a 7-year-old girl with sickle cell disease who was presented with altered mental status and hypertension after a blood transfusion. When she was initially hooked up to EEG, we saw that she was seizing over the right posterior region. And when we imaged her, we had evidence of diffusion restriction and flare abnormalities over the biposterior regions, which sort of confirmed that this patient had what we call posterior reversible encephalopathy syndrome, or PRES. We treated this patient aggressively with pentobarbital therapy to get her seizures under good control. But after we weaned this pentobarb, we started to see that there was generalized periodic discharges that evolved on her EEG. Now, is this seizure? Is this not seizure? Sometimes we do see GPDs after pentobarb withdrawal. And so to better ascertain whether this was a ictal or interictal pattern, I performed bedside TCD during the pattern. We found that mean flow velocities over the left middle cerebral artery here were 44 centimeters a second, so not elevated. We saw similar symmetry. We saw similar mean flow velocities over the right hemisphere. I measured a little bit later, and then we sent her for MR perfusion, and we didn't find any evidence of increased perfusion. So on the basis of this, we did not escalate AED therapy. We continued our pentobarb. We coming off of pentobarb, and about 28 hours later, 40 hours after the pentobarb wean, we had a normal interictal EEG, and this patient was waking up and opening her eyes. So let me go to the final case example. This is a patient with traumatic brain injury. This is an 8-year-old boy who suffered a subdural hematoma after experiencing blunt trauma. Because of this traumatic brain injury, our neurosurgeons did an evacuation of the subdural hematoma over the right side, and as part of our intracranial monitoring strategy, they got multimodality monitoring, which included intracranial pressure monitoring, brain tissue oxygenation with the Lycox, and we also placed intracortical electroencephalography over the left temporal region. This also, this paradigm also, of course, included surface EEG recording. So I want to go through a trend of this patient's cerebral physiology and electrical activity over the ensuing days. So this is the patient's EEG at the initial time of being hooked up on day 1. So what you can see here on the right is that the left hemisphere has evidence of some slowing, but some mixed frequencies, and evidence of sleep spindles, suggestive of intact corticothalamic integrity. On the right hemisphere, on red, we see less of that faster frequency, and we see no sleep spindles present. At the bottom, we have our intracortical electroencephalography, our EEG over the surface of the right temporal area, and what we see is slowing and some intermittent high amplitude, sharply contoured waveforms. So On the left here, for this entire diagram, I want to show you that the trend of cerebral physiology. What I have here is intracranial pressure monitoring, cerebral perfusion pressure, arterial blood pressure, CO2, and heart rate. At the bottom, I have the total power of the left anterior cerebral artery electrodes as well as the depth EEG. And what I want you to observe is that after the first couple of days of recording on this trend, you notice that heart rate variability starts to go down, and at that same time you have a gradual evolution and increase in total power within the depth EEG activity. And let's observe what really happens during this time and what's sort of making sense. So let's go to the second day after injury. I have the time trend here over a period of 6 hours. We see plateau waves that are occurring, but not real significant changes in terms of the EEG activity at that time. We go to day 3, this is when we start to see that increase in total power over the depth EEG. And what we find is that during this period of time, there's an increase in interictal spikes on the depth electrode, but we don't really see anything changing on surface EEG. We go over this period of time. We go to later in day 3. We continue to see those interictal spikes on the EEG. We go to a later time point, we start to see rhythmic slowing on that depth EEG, and we start to see some sharply contoured waveforms over the left hemisphere. And then we go to day 4, and we really start to see some rhythmic activity on that depth electrode, that depth EEG. It had mixed with superimposed spikes, and now we're seeing on the left side that we're seeing superimposed, sharply contoured waveforms, and some that look suspicious for some sharp waves. Now I want to sort of focus in on the last day of the recording, and here on the time trend you have just one full day. And so at this point, that I sort of have on red on our CNS reader, we have very rhythmic slowing on the depth electrode. We have admixed spikes over the left hemisphere. That right hemisphere still seems suppressed. What I want you to observe here is that take a look at that total power over the left ACA area, the surface EEG, the surface EEG electrodes over the left frontal portion of the brain. And what this shows us is that you can see that there is somewhat of a relationship. You can see that there is a relationship between that total power and the trend in intracranial pressure. So let's follow this trend. Right here, we got an ICP of 22. We got some very sharply contoured, semi-rhythmic sharp waves over the left frontal area. Here, you see it again. We see a trend down in ICP after we sort of play around with hypertonic saline. We get that ICP down to 17. At this point, the depth electrode is no longer working, and I'll explain why. You'll see in a little bit. But we see a relative reduction in the left hemisphere of that sharply contoured waveforms, and the amplitudes come down. But as we get to an ICP of 24, we start to see more rhythmic sharp waves over the left frontal area, and when we get to an ICP of 29, it is very rhythmic, it's very high amplitude, and it's very suspicious for seizure activity. So on the basis of this, we take this patient down for a scan, and what we find is that the patient has developed significant swelling over that right hemisphere, and as a result of that, our surgeons do a decompressive hemicraniectomy. After this is performed, we bring the patient back to the pediatric intensive care unit, and without changing any anti-epileptic therapy, we take a look. Now we have ICPs of 4, far lower, and if we look at our electrical activity, we do not have the same rhythmicity, amplitude, or epileptiform features on that left frontal area that we did before. So we can really see here that there's a change in EEG that really corresponds with changes in intracranial pressure. And looking at all this, we can really get a sense that there was a strong relationship between intracranial pressure and changes on both the depth electrode as well as the surface EEG. So I hope this presentation gives you a sense that electroencephalography can provide unique high temporal and spatial resolution data to better understand real-time cerebral physiology. A variety of EEG biomarkers such as seizures, Ictal-Interictal Continuum patterns, and background continuous EEG patterns carry associations with alterations of cerebral blood flow, metabolism, and function. And that better understanding those changes in any individual patient's EEG in real time in relation to multimodal neuromonitoring may augment our capacity to detect and prevent secondary brain injury. I thank you for your time and ask what questions you have.
Thanks very much, Brian. That was an amazing presentation. At this point, please get your questions in so we can review them prior to the Q&A session, which will start in a few minutes. So we'll now move on to our featured industry partner. Our partner this month is Persist Development, founded by Scott Wilson back in 1987. In addition to EEG as a common interest, Scott and I are both surfers from way back. He had the better waves in California, and I had slightly smaller ones growing up in South Florida. So Persist has been a great partner of ours for many years now, and they have some new features for nursing stations and mobile data review that you'll see in a minute. Persist is one of 3 EEG processing and remote review solutions available for our monitor. Our own CNS reader focuses on multimodal data and EEG trends, and it's what you saw in Dr. Appavu's presentation. AIT makes in CVIS, which has some nice features for automating EEG classification. But the most widely used EEG trending and review software is from Persist Development. So let's roll a short video from them and see what they're doing that's new.
Persist is the world's leading quantitative EEG software and is compatible with and sold by every major EEG manufacturer. Persist includes a universal EEG reader and is used for real-time continuous monitoring and analysis of EEG. Persist first applies the only FDA-cleared artifact reduction algorithm to the raw EEG. Using signal processing techniques, artifacts are reduced without attenuating the cerebral signal. The raw EEG, shown in gray, and the artifact-reduced signal, in black, are presented to the expert reader. State-of-the-art machine learning algorithms trained on hundreds of highly curated clinical EEG recordings produce concise, clinically relevant, and customizable views of the EEG that assist experts in identifying areas of interest in the record. As an example, in this default trend panel, we can see from the eye movement artifact that the patient is awake. Their eye movement decreases as they begin to fall asleep, and spikes begin to occur. The spike bursts increase, they have a seizure, and go back to sleep. Multiple patients can be monitored simultaneously using the Persist multi-patient monitor. Active recordings can be manually or automatically assigned to cells in the multi-patient monitor. Each cell shows the active trend panel for the assigned patient, so the most relevant panel can be selected for each patient. Clicking on any cell brings that patient record to full screen and allows viewing of the EEG. The Persist mobile app allows you to quickly and easily review EEG, trends, and video, add comments to records, and receive customized notifications, all on your tablet or mobile phone. The mobile app has 4 patient views. The patient list view, shown here, shows all active patient records by unit. Selecting a patient record brings up a filtered list of comments in the record. Selecting a comment brings up the relevant section of the trend. Using the touchscreen, you can slide to other parts of the trend, and using the arrows, you can move to the next comment. Many of the trend controls found within the full Persist product are available within the mobile app. Selecting Show EEG shows the EEG corresponding to this point of the trend. Like the trend view, you have many of the same controls as the full product to allow you to focus on specific details of the EEG. There is a split screen view showing the synchronized EEG and trends. Pressing the play button on any screen plays the recording at the selected speed. You also have the ability to add comments of varying length and view video. In addition to the patient list view, there is a patient monitoring view similar to the multi-patient monitor product. There's a notification view summarizing recent notifications, and a slide view that cycles through all active records. Persist Mobile is cleared by the FDA for clinical use and is secure, functioning entirely within your firewall. No PHI leaves your control or is stored on your mobile device. If you would like a live demo or to learn more about Persist, the multi-patient monitor, or the mobile app, please contact us at sales@persist.com. Thank you.
Thank you. So once again, please send in your questions. We will now go live to Dr. Appavu in Phoenix for our Q&A session.
All right, hello. Thank you, Dick. All right, let's take a look at some of these questions. Hope you guys can hear me. All right. So let's start with a few of these. All right, we have, thank you very much for your excellent talk, Dr. Appavu. What's the causal relationship between intracranial pressure and EEG ICP signals, ICP changes? Do they cause changes in EEG or So let me sort of look at this question. What's the causal relationship between intracranial pressure and EEG? That's an excellent question. I don't think we completely know the answer to that. I showed one example of a situation where we saw a total power within the area of where a patient appeared to be seizing, and we found that there was a coherent relationship between that and intracranial pressure. I don't know if that's always going to be the case for every patient. It could be certain patients where you see certain relationships and others where you see different relationships. Perhaps with patients who have increased intracranial pressure, you can have a drop in cerebral perfusion pressure, and as such, you may have a reduction in faster frequencies. So I think there are things that we can identify sort of patient by patient. If we look at the EEG really in terms of its high resolution character and notice whether there are specific variables within that electroencephalography that change with the ICP that we might be able to pick up and see a relationship. But I don't know if there will always be a sort of a consistent pattern that we know just patient by patient. It may, if we do find that pattern, it may be relative to some degree of changes in physiology, especially reductions or alterations in cerebral perfusion pressure. So now I'm going to go to another question. Could the dosage of anti-seizure medications, Depakote for example, be precisely controlled in real-time monitoring for these signals? I don't know if you can get necessarily the dosage of the medication. You can figure out what the dosage is, but you can see what degree of an effect that it might have. If you have a patient that's in status, for instance, or having repetitive seizures, you can mark it in multimodal monitoring, particularly with the Moberg device, which actually it does really well. You can have the nurses or you yourself can mark when the event occurred, and you can look at what is the impact of that anti-epileptic in terms of treating, in terms of reducing sort of the seizure burden, or perhaps changing the interictal pattern in terms of its degree of spikes and whatnot. Certainly we use medication infusions where we might start, if a patient's in status epilepticus, we might be titrating midazolam, and we can sort of annotate in a multimodal monitoring system, okay, go up from 0.2 mg/kg an hour to 0.3 to 0.4, and then you can see as you notate how you change the concentration, how it really impacts the background EEG. Have another question. What do periodic discharges truly indicate? And this, the person here wrote, this may be a naive question, and I would argue back, it's not a naive question at all. It's actually a great question. We don't completely know what they represent. We don't know if they are sort of an epiphenomena or sort of whether they're a direct contributor towards brain injury. What we can see, based on really the latest literature that I think Dr. Clausen had put out, that I had shown in my presentation, was that it seems like at higher frequencies they both contribute to increased seizure prevalence, and they actually cause brain tissue. They seem to be directly associated with brain tissue hypoxia. So there does seem to be a relationship there, and we can, for any individual patient, we can test out if we are able to time lock our continuous measurements of perfusion and oxygenation within the brain with those periodic discharges. We can test by providing an intervention to space out those discharges, to attenuate them, and see whether that intervention makes a difference in terms of the periodicity, the intensity, or the frequency of those discharges, and really see that cause and effect with an intervention may perhaps give us an idea of what they truly indicate. I think it's more cause and effect interventions and studies that at a larger scale that really look at that are going to tell us what they truly, give us a better indication of what they truly indicate. All right, let's look. Let me look at some more questions. Could an expert system watch for patterns in TCD EEG correlation and make treatment recommendations? Perhaps. I think there's a lot of things. I think any modality that looks at perfusion, such as TCD, with EEG signals, can allow you to determine whether a pattern is sort of ictal or not. Well, actually, is it whether a pattern's contributed to brain injury or not, and sort of brain care. If your fundamental question is how do I maintain perfusion, adequate perfusion, and to the brain, and maintain it within an autoregulated state where secondary brain injury is less likely to occur, then I think a system could be devised. It's certainly feasible, and it certainly could be tested. So any modality, whether it's TCD or whether it's the parenchymal brain perfusion monitor, anything, or a brain oxygenation monitor, could give you those sort of clues. And so I think that's sort of where the future is going to be in terms of ascribing how to treat these patterns. All right, another question. There is no question that many, if not most, patients with significant brain injury have seizures during the acute period. They mentioned Larry Hurt's data with depth electrodes. There are other studies, however, that show that prophylactic anticonvulsant medications in that population do not improve outcome, and then it's commented that they may actually worsen outcome. Is there any data that you are aware of that recognition of subclinical ictal or periictal patterns in this population actually results in improved outcomes? So that's a great question. Let me sort of directly answer that question and say I am not aware of any data that suggests that the recognition of these actually improves outcomes. However, there is data, and we've looked internally within our data that shows that in traumatic brain injury, that the presence of post-traumatic seizures is associated with poor outcomes. So it does ask the question, does treating against those seizures improve outcome? I think there's a couple ways you approach this, and you can approach this in the setting of multimodality monitoring data. So if you're treating post-traumatic seizures with seizure medications, that might be one way that you perhaps could improve metabolism within the brain by and perfusion within the brain by sort of putting the brain in a better state by not seizing. On the other hand, if there is if the physiologic environment is one that puts the patient at risk of seizures, then that environment then we perhaps need to focus on what sort of sets up that environment and what can we improve upon that environment so that we prevent the emergence of these ictal phenomena. And that's where this multimodality monitoring really becomes important and into play. We need to understand what is that environment that leads to the ictal phenomena, that leads to the development of Ictal-Interictal Continuum patterns or cortical spreading depolarizations, and manage perfusion, pressure, and metabolism to create a better environment. So going back to your question, no, we don't have any evidence to suggest that these patterns are, that recognizing these patterns has improved outcome yet, but understanding what causes them, what leads to them, and what may effectively treat the underlying source is, I think, going to be the real key to looking at how we observe that phenomena and how we lead to a method to improve outcomes in those patients with those injuries. All right, another question. The number of lines and electrodes attached to a patient can increase the likelihood of ICU delirium. Is there a way to decrease the number of electrodes but maintain the utility of the EEG in the ICU setting? That's a good question. That's a great question. I think it's really important to work with your EEG technologist and to sort of evaluate where you want to put your electrodes on, and really take into account where the pathology is within the brain based on your MRI scan, where you may have availability in the scalp, especially with a patient perhaps with a traumatic brain injury or a multi-bolt system, and sort of identify where you want to put the electrodes. You also want to take into account how long you want to keep electrodes on, whether you want to give breaks with them. So those are important factors in terms of deciding, in terms of looking at the utility of it. So you really have to take the patient into account in terms of where things are, where their where their injury is, where you're looking at their brain waves, and you want to take into account when you do your initial EEG where abnormalities are occurring and where you are looking for future abnormalities to occur. Are you looking for the possibility of a vasospasm in a particular area? Are you looking for swelling to develop in a particular area? These are the things that you really need to take into account for, and perhaps if you need to decrease your electrodes at a certain period of time, you can do that in sort of an intelligent fashion. All right, another question I have. Is there any relationship between cerebral blood flow and EEG? If so, the most significant relationship between the two is located in which frequency of the EEG? So it is, as I mentioned, it's the faster frequencies that are the first thing to drop as you lose perfusion. It's a really classic sign. If you ever look at the EEG of a patient with cardiac arrest or that herniates, you can really see it on a dense spectral array, that it's that drop off of the faster frequencies that goes first, then you start to lose gradually slower frequencies until when you have really no flow at all, that you get into burst suppression and then full suppression. So that is a relationship that exists, and it's really important to us to find great ways that we can sort of harness that information and to really understand perfusion in relation to EEG. When you have SERPIDs, if any, what do you instruct the nurses to do in terms of limiting stimulation? So right now, typically I don't really tell them to do too much. I will, when we do identify SERPIDs, we do keep an eye on them. The study that I mentioned that we just sort of, I presented with a group at Columbia at Neurocritical care, we really saw that the SERPIDs that were over 5 to 10 minutes were the ones that really were associated with hypoxia. But most of the time that we do see SERPIDs, they're actually they're relatively shorter in duration. So if they're short in duration, I'm not going to tell a nurse to really limit their stimulation. But if they do become prolonged, and we're looking at a multimodal monitoring system, that's when we really sort of try to identify, okay, are we causing hypoxia or not? And then acting in that regard. So I sort of take it patient by patient, but I do think it's important to sort of recognize that these patterns could be associated with hypoxia. All right. Are there any other questions?
Okay, Brian, thank you very much.
Okay, thank you.
If there are no more questions, really appreciate the webinar. It was excellent. And also I'd like to thank all of our participants for joining us, and especially thanks to those connecting from Europe very late on a Friday night. We'll have a recording of this webinar available on our website within a week. If you have suggestions for topics relevant to neuromonitoring and to neurocritical care, please get in touch with us at info@moberg.com. And thank you very much for joining us. And we'll see you at the next webinar.